Good morning. My name is Mary Lou Smith, and I'm a neuropsychologist. I work at the Hospital for Sick Children in Toronto and the University of Toronto. And my life has been immersed in the field of pediatric epilepsy surgery for decades and decades. So it's very exciting for me to be here today and to learn more from this audience. I just want to make a comment that I'm really impressed that Dr. Kolb snuck into this room early this morning and painted all these very elaborate neurons all over the wall to give us the context and the setting for today. Good work, Brian. That's why you got the Order of Canada. You're always thinking. Okay, so I want to talk a little bit about memory after resective surgery in children. And I want to start out by pointing out that, in fact, there are many different kinds of memory. We use this term as a big catch-all, but we have memory for personal experiences, so you'll go away after today and you'll remember some details of what was said and who you talked to, who you met. We have memory for facts, for word knowledge, that's called semantic memory. There's working memory that Ken just talked a little bit about in the context of his daughter's difficulties. And there's procedural memories where we learn new motor skills or new procedures. And if you look at this diagram, which I won't go into in detail, but you can see different parts of the brain of the neocortex and then subcortical structures, and you'll see that all of them have to do with some kind of memory, and many with more than one kind of memory. So it's not surprising that when a child has a removal, surgical removal from some part of the brain, that there's the potential for memory to be affected. So I'll just say a word about the importance of memory, and I think you can all relate to this because I would probably bet a lot of money that there's not a single person in this room who at one time or another didn't say, I wish I had a better memory, or I wish I could remember that, or I wish I didn't forget that. So we all relate to the importance of memory in our everyday function. And childhood, of course, is a stage of very rapid learning and memory. A huge portion of the child's life is spent in school, where there's an emphasis on learning and retention. And we know from research that in childhood epilepsy, memory is an important predictor of quality of life. And also our research has shown that in a very high portion of children with epilepsy, not only those who go on to surgery, but in general in children with epilepsy, there's a very high rate of memory impairments. Now I want to point out, and you're going to be hearing more about this today, about other aspects of cognition, but you can't just think about memory in isolation because there's lots of other aspects of the child's cognitive processes that can impinge on memory. So if a child has an intellectual disability, they might have poorer memory. If they show poor attention, that's going to affect their memory. If you can't pay attention to what's going on around you, you're not going to encode it and remember it. A lot of children with epilepsy have what we call very slow processing speed, so their ability to take in and understand and follow information is slowed down, and that's going to impact on what they can encode and retain, and also difficulty with language. So if you don't understand what we're talking about today, you're not going to remember it very well. So all of this constellation of factors can also impact on a child's memory. So what do we know about memory after large resections in childhood? Well, first of all, most of the work has been on relatively short outcomes after surgery, and we heard from our neurosurgery panel earlier today that they wish they had more information about longer-term outcomes, and parents want to know that too. What's going to happen when my child's 13, when my child's 18, when my child's 26? Most of the research has been done on children with temporal lobe resections. And I'll talk a little bit about that in a minute. And this diagram shows you, just to remind you, where the temporal lobe is in the brain, and that within the middle part of the temporal lobe, there's a very important structure for memory called the hippocampus. And I'll mention that again in a few minutes. And I was only able to locate one study which was provided a follow-up of individuals who had hemispherectomy in childhood and actually investigated memory. I should say I found 2 studies, but one was so bad methodologically. As I kept reading it, I was getting madder and madder and madder, and I couldn't finish it. I said, I'm never going to talk, nobody should ever talk about that study. You can't draw any conclusion. So I'm just going to pretend there's only one study. Okay, so a few years ago, a paper was published that provided a systematic review of outcomes of pediatric temporal lobe resection with respect to memory. And they looked at the results in 2 ways. One is what we call at the group level, where studies have pooled all their patients and looked at the average outcomes. And of the 18 studies that were reviewed, 11 of the 18 showed no statistically significant change in memory after surgery. Okay? So that's good. The majority of studies are showing that memory is not getting worse. It's not getting better, but there's no change. At the individual level, when you look at each individual child and you say, is this child's memory improved, the same, or decline, then you see that in 57% of the studies, memory was, 57% of individuals' memory is stable. There's an improvement in only 17%, and there's a decline in about 25%. Now, I would say that what we don't really understand fully is the constellation of factors that's going to tell us who's going to improve and who's going to decline. So that's an area that we need to do more research, and we have some hints here, but not so much here. Oh, I'm stuck. There we go. All right. So is there any evidence for neuroplasticity? And this question was raised in this study from Germany, where they compared 2 groups of individuals who underwent resections from the left temporal lobe, and they looked at verbal memory outcomes. And one group were children at the time of the surgery, and another group were adults. And the 2 groups were matched in terms of the age at seizure onset and the extent of the surgery and so on. And what you can see here is that they had a preoperative baseline, and then they looked at the patients 3 months after surgery and then 1 month after surgery. And both groups, both the children and the adults, showed an initial decline, although it was somewhat steeper in the adults than it was in the children. But what was interesting was at the 1-year follow-up, the children had gone back, so they were pretty close to their preoperative baseline, whereas the adults did not show that recovery. So this group argued that this was evidence for neuroplasticity in the children, and that it takes some time to declare, but by about 1 year after surgery, you can indeed see some improvements. However, we do not find that this neuroplasticity or this improvement is seen in all children. So this is a study that we did at Sick Kids, where we looked at left and right resections. We compared them on children on a verbal learning and memory task where they had to learn a list of words that were repeated to them several times. And here on this part of the graph, you see the children who had left temporal lobe resections and those who had right temporal lobe resections. And the resections only included the lateral part of the temporal lobe. They did not include the hippocampus, that part that I showed you earlier in the diagram, which is an important structure for memory. And here on the right, these children had both the lateral resections and the hippocampus removed as well. The blue bars are for preoperative performance, and the red bars are for postoperative performance. And this shows the follow-up was done 1 year after surgery. And what you can see here is that those children who had left-sided resections that included both the lateral neocortex plus the hippocampus were really affected negatively by the surgery in terms of their verbal learning. And at 1 year post-op, you can see that they're still quite impaired, that they are very impaired on this task. Those who had right-sided resections were not affected as much. This is not, although the left lateral kids took a little bit of a hit, this is not a statistically significant a decline. So this plasticity that the previous study seemed to allude to, we do not find in those children who have the hippocampus resected in their surgery. So that's a message you surgeons can tell your patients when they're looking at outcomes. I'm stuck again. Is there anybody back there who can help advance the slide? Oh, yeah, that's it. Okay. So when we think about plasticity, and as Dr. Cole told us very eloquently earlier today, the brain is changing over time as we age. So it's quite possible that it might take even more time than 1 year for this change to declare itself. And so I want to talk a little bit about what we called our long-term follow-up study that we did in Toronto, and I worked quite closely with Claudia Puca, who's going to talk to you a little bit later today as well, on this particular study. And we investigated all kinds of cognitive and behavioral and quality of life outcomes in 2 groups of children. One group were children who had epilepsy and went on to have surgery, and the other group were children with epilepsy who did not have surgery. And all of these children had had a neuropsychological assessment at the time that they were being investigated for surgery, and then we followed them up 4 to 11 years after surgery. So we had a baseline as well as a longitudinal follow-up, which was important. Could you advance the slide for me, please? Thank you. So we did not, first of all, I want to say we did not find any effects related to whether or not the child had surgery. So it didn't matter. There was no difference in performance between these 2 groups. And in a way, that's good news because we can tell parents that if your child has surgery, they're not going to lose, the chances are they're not going to lose function. But what was really important was the seizure status at the time of follow-up, whether or not the children these individuals were having seizures in the year prior to the time that we saw them for this long-term follow-up. Advance, please. Thank you. Okay. So here are our results for 4 tests of memory: recall of the details of a story, the ability to recognize faces that they had just recently encountered, their ability to learn associations between words, and the recall of a list of single words. So this shows, in the blue color is those individuals who were seizure-free at the time of the follow-up, and the red are those who were still having seizures. And here we've combined the surgical and the non-surgical cases because there was no difference between those 2 groups. First of all, what's interesting is that, and here we have the baseline and the long-term follow-up, and what was interesting was that for the story recall, face recognition, and the word-paired recall, we actually found that those individuals who were seizure-free at follow-up had from the get-go, they had better memories than those who continued to have surgery continued to have seizures or who had a relapse. So there was probably something in their brain, the dysfunction in their brains that led to them to continue to have seizures or to relapse and have seizures, and also weakened their memory systems. But there were no significant changes over time in these 3 kinds of tasks. Where we did find a difference was on this task where we had children learn over multiple repetitions and then recall lists of words. And surprisingly, we found that both groups declined on this particular task. So this is one aspect of new learning and encoding and retention that seems to be significantly affected by having a history of seizures. Advance, please. Thank you. Okay. Now, when we looked at these same cases in terms of whether or not each individual showed stability, improvement, or decline, this is what we found. So if you improved, the bar is above the line, and if you declined, it's below the line. And this is the number of cases that improved or declined. And what was interesting was that it didn't seem, for many of the tasks, it didn't seem to matter whether or not the individual was seizure-free or continued to have seizures in terms of whether they showed improvement or decline. So this is what I mean. We still have to go on to do our research to try to understand. It's not just seizure freedom that seems to predict here. However, for that word list recall, which seems to be a task that's very sensitive to these kinds of memory impairments in these children, we did see that a greater number individuals declined over time than improved. Advance, please. Thank you. And this when we saw improvement, it was associated with lower baseline scores. So this is also encouraging that those children who were the ones who were doing more poorly at the get-go before they had, when we first saw them, were the ones who were more likely to show improvements. And we saw that children who were older at the time of surgery were more likely to show improvement on the story recall task. And this decline that you see here, and I showed you in the previous slide, seems to be most characteristic of individuals who actually had surgery outside the temporal lobe. And many of these individuals had multilobar surgery, so they might have had frontal, parietal, occipital combinations. Next, please. Okay. Now, this is a study from the Great Ormond Street group in London, who did a long-term outcome study of memory after temporal lobectomy, and they found that there were some improvements in memory over time, and those improvements seemed to be confined to the memory functions that we associated with the hemisphere that was not operated on. So what you can see here is this left surgical, right surgical, and control. These are kids with epilepsy who didn't have surgery. This is a task asking children to recall the details of a story. And what you can see is that in long-term follow-up, those children who had right-sided resections showed an improvement on this verbal memory task. And we see the reverse for a task of visual recall, where now it's the left surgical cases who are showing this improvement over time. Notice that the lefts did not improve in the verbal memory task. Notice that the rights did not improve in the visual memory task. But on the kind of memory that seems to be subserved by the other hemisphere, we see this advantage. Thank you. Okay. And finally, this one study from the Netherlands on individuals who had undergone hemispherectomy. And they had followed up 31 individuals who were seen, I think it was 5 or more years after surgery. They subdivided them into whether they had developmental types of pathologies, acquired types of pathologies, or progressive types of pathologies. You could see that they were all very young when they started to have seizures, and relatively young when they had surgery, although there are some differences here. So the children in the progressive group, that includes Rasmussen's encephalitis and Sturge-Weber, were older than the children, say, who had hemimegaencephaly or cortical dysplasia. But what was interesting is that when they looked at the number of their 31 cases in whom age-appropriate testing was feasible, you can see that a lot of these individuals were not able to participate in the cognitive testing at the outcome. And here you can see their results. So they divided their participants into 2 ages. There were 8 who were young adults at the time of follow-up and 14 who were school age at the time of follow-up. And the range of intelligence spanned from 56 to 80 in the young adults and 45 to 82 in the school age group. And just for your reference point here, I put what is the normative value. So we consider an IQ of 100 to be average, and the average range is between 90 and 109. So these individuals, their impairments ranged from being quite severely to below average to being in the borderline range. Here's their performance on a measure of digit span, which is considered to be a way of looking at short-term or working memory. Here's what we would consider the average range, and you can see that there's a considerable spread in the performance of the young adults and the children. And you can go down this as well. And again, I think the important point is that there's this huge range from very impaired up to the average range across these different measures of memory. Now, what we can't say from, so this study leaves us with lots of questions. What explains this variability? Why do some do so well and some not do so well? And how does this compare with how they were doing before surgery? And we don't know the answer to that question because there was no pre-surgical baseline. Many of the children were too young to be tested on memory. Many of the children were too impaired to be tested on memory. So this is the only study that I was able to locate on hemispherectomy, and it just leaves so many unanswered questions. And advance, please. Thank you. So just in conclusion, I want to leave you with these messages that children who undergo temporal lobe resections are at decline for memory if the hippocampus is removed. We also know if they're at risk if their memory was normal before surgery. There are few long-term follow-up studies that have been done suggest that there may be some advantages associated with surgery or at least becoming seizure-free. And we certainly need more research on memory after hemispheric resections. Thank you.